must be able to recognize the early signs of stroke and know how to activate the EMS system as soon as possible.
Grace, you're scary.
Is she having a heart attack?
Dr. George told us about this. I think she may be having a stroke.
I'll call in the morning.
No, hey, the doctor said not to take the card. Please call 911.
Currently, over half of all stroke victims are transported to the ED by family and friends. However, the EMS system can provide initial care and screening and can alert the receiving facility to prepare for acute stroke care and intervention.
All right, sir. Is she conscious?
Yep, she seems to be conscious, but she's having some trouble talking.
Is she completely awake and breathing okay?
Yes, she's completely awake and she seems to be breathing okay.
Tell me why you think she's having a stroke.
Well, she's having some difficulty speaking, and she's having a really hard time doing everything on the right side of her body.
Most strokes occur at home, and many stroke victims often rationalize or deny symptoms. As a result, EMS access and treatment are often delayed. These delays may limit the use of fibrinolytic therapy or other interventions that may improve outcome from acute stroke.
Rescue 21, 34 Boardwalk Avenue, 65-year-old female, possible stroke, timeout 11:27.
This is why the second step in the 7 Ds, dispatch of EMS, is so important. Since treatment of brain hemorrhage is an emergency and use of intravenous fibrinolytic treatment for ischemic stroke must be provided within 3 hours of symptom onset, recognizing a stroke early is critical. In this case, the EMS team was contacted right away. By the time they arrive on the scene, 6 minutes have elapsed from the time of symptom onset. Having been told of a suspected stroke, the EMS providers will need to perform several actions to quickly identify a possible stroke victim. Support of the victim's ABCs is the first and most important step.
Hi, what's your name?
Grace Wilson.
Mrs. Wilson, my name's Kevin. It looks like you're having some trouble today. What is it?
She started to fall down.
Do you have any pain or discomfort anywhere? Okay, so you don't have any chest discomfort at all? Are you having any trouble breathing? Okay, that's good. Listen, we're going to get your vitals, we're going to give you some oxygen so we can figure out what's going on with you, okay? Mr. Wilson, is your wife diabetic?
No, she's not.
Has she ever had a seizure before?
No, never.
EMS providers will need to try and rule out other possible causes of the victim's condition, such as hypoglycemia and seizures. The EMS providers will obtain a brief medical history, and if allowed by protocol or medical control, may obtain a blood sample to evaluate the blood glucose. In all cases where stroke is suspected, EMS should perform a pre-hospital stroke assessment screen using tools such as the Cincinnati Pre-Hospital Stroke Scale or the Los Angeles Pre-Hospital Stroke Screen. The first indicator to look for in the Cincinnati scale is facial droop. Have the patient attempt to show his teeth or smile.
Okay, listen closer. Can you smile for me? Try to smile.
Facial droop is present if one side of the patient's face does not move as well as the other.
Now I want you to close both of your eyes and try to hold your arms straight out with your palms up.
If one of the patient's arms does not move or one arm drifts down compared with the other, this is a sign of arm drift.
Now listen, I want you to repeat after me. I want you to say this. You can't teach an old dog new tricks. Can you say that?
If the patient slurs words, says the wrong words, or cannot speak at all, this is a sign of abnormal speech.
That's good, thank you.
If one or more of these indicators is abnormal, the probability of a stroke is 72%. The next steps are crucial to providing effective treatment for a suspected stroke victim. Providers should determine the time when the patient was last known to be normal. This will be time 0 and will be used to track the window of opportunity for fibrinolytic therapy.
Sir, do you remember about what time you first noticed your wife's symptoms?
We called 911 immediately after symptoms started. It was about 5 or 6 minutes ago.
So about 11:25 a.m.?
Yeah, that's about right.
Julie, looks like we've got a potential stroke victim here. I think we should get her to county medical right away. Mrs. Wilson, we're going to get you to the hospital so you can get checked out, okay? Mrs. Wilson, you can ride manage with us, sir.
The victim should be quickly transported to a hospital that is equipped to deal with an acute stroke. If possible, a family member or friend should accompany the patient to help answer questions. After the initial pre-hospital assessment, effective delivery includes transport of the patient to a hospital equipped to deal with acute stroke, preferably accompanied by a family member or witness. The EMS provider should monitor the victim's vital signs and monitor and support cardiac, respiratory, and neurologic function. They should notify the receiving hospital that a victim of possible stroke is on the way.
Rescue 21, go ahead with your report.
We're en route with a possible stroke patient, 65-year-old female. She's had sudden onset of weakness on the right side, also facial drooping on the right side, difficulty speaking. She has no complaint of chest discomfort. Vital signs are as follows. Blood pressure is 190 over 110. Heart rate is 82. Respiratory rate of effort or adequate. Her glucose level is 110. 12 lead is non-diagnostic for ST segment changes.
She received supplemental O2 by nasal cannula at 4 liters. The septic onset was approximately 14 minutes ago at about 7:25 a.m. and our ETA is 5 minutes.
Affirmative, Rescue 21 will be expecting her. We'll notify the physician and the stroke team.
EMS rescuers should provide advance notification to the receiving hospital to allow the ED to quickly prepare for the arrival of a possible stroke patient. Time is of the essence since there is a limited window of opportunity to evaluate the patient, determine eligibility for fibrinolytics, and administer the therapy to appropriate candidates. The sooner fibrinolytic therapy is administered, the greater the chance for a better recovery.
Okay, we're going to go to room 1. That's our suspected stroke victim. She's headed for acute bed 1.
Providing effective triage at the door of the ED and assigning the patient to a room takes us through the 4-step in stroke diagnosis and treatment. Protocols should be used in the ED to minimize delay to definitive diagnosis and therapy. An immediate assessment should be made by the ED physician within 10 minutes of patient arrival, with the time of onset of symptoms established. Assessment steps should include assessment of the patient's ABCs and vital signs in support of the airway as necessary. Oxygen is continued or initiated in hypoxemic patients. Establish or confirm IV access and obtain blood samples for electrolytes, CBC, and coagulation studies. Checking blood glucose and providing treatment if necessary. The ED physician should perform a neurologic screening assessment, order an emergent CT scan, and activate the stroke team or consultant if pre-arrival notification was not given. A 12-lead ECG is performed but does not take priority over the CT scan. It may identify a recent MI or arrhythmia as a cause of stroke. Notification of the stroke team.
Now we will start our discussion. First of all, why this station is here in ACLS? What is the relation between cerebral stroke and our ACLS stroke? Anyone have a idea? What else? Because mainly the origin of the emboli, which obstructs the blood vessels going to the brain, comes from the cardiovascular system. This will bring us to classify this stroke. This stroke either is hemorrhagic or embolic. I mean ischemic. Ischemic stroke is about how many percent? 87%. Hemorrhagic, how much? 13%. From this hemorrhagic, which is 13%, 10% is due to intracerebral hemorrhage, and 3% due to subarachnoid hemorrhage. In all cases, especially in ischemic means that some emboli came from somewhere in the cardiovascular system, and this emboli all of a sudden obstructs the blood vessel going to the brain, leading to ischemia of this part of the brain which is supplied by this blood vessel. For that, we have to act fast, because the matter of the brain cannot tolerate more than 5 to 6 minutes without blood and oxygen, or else it will go to what is called liquefactive necrosis. It means death. So here in this station, time, it means neurons, death of neurons. Here, time is brain, which is something precious. In the lecture, Dr. Ahmed will deliver after a few minutes. Acute coronary syndrome, time is heart muscle. In our lecture, time is brain. So we have to act fast. We have here what is called golden hour. We have to act within this golden hour. Forget about the area which died. We cannot save it anymore. But around this area which died, there is another area subjected to some sort of ischemia, less blood supply and less oxygen. This area, we call it penumbra. So our goal is to save the area, the big area around the occluded blood vessel. So, to act fast, we have first step to detect the symptoms and the signs properly. First symptom or sign is sometimes it can subtle. I mean, very slight symptoms and signs which most of the time we neglect it. But for you, as a medical professional, you have to detect it. For example, blurring of vision, altered mentality, slurred speech, facial growth, weakness, feeling side of the body, even a change in the smell. All these necessary to be all together, but it can start by only one of these manifestations is a clue towards early detection of CVA. So you have to adapt to yourself, you have to be smart to detect these early manifestations of CVA. And after that, you have to go fast to the center where it is well prepared to receive stroke. So now at home you have one of your relatives which started to show these first symptoms of CVA. What you have to do? Is it better to drive him quickly to the hospital or to call the ambulance? What do you think? Why? Okay.
Ambulance is more rapid and more accurate. In 2 words. More rapid and more accurate.
Suppose that the ambulance told you, the ambulance driver told you will come to you after 10 minutes, and you think that if you drive this patient to the hospital, it will take only 5 minutes.
This is usually uncorrect because the ambulance has its warning lights and the chemical patient more rapid than the car. Unless you found the way is
Okay, but the most important is that those EMTs and this ambulance, he knows very well which center is well equipped and well trained to receive such cases. So if you drive, you may think that this is a hospital, a nearby hospital, so to drive my relative to this hospital, when I reach this hospital and after I spend over there about half an hour, they will tell me to drive him again to another hospital. So this ambulance, he knows very well what is the proper place to deliver this patient. And not only that, but again, they can
notify the destination.
exactly. There is what is called pre-notification by whatever, by paging system, by whatever. There is pre-notification to call the stroke team, because in these centers there is a stroke team to be ready to receive this case in ER. So, because they have a map for the area and they know what is the center to deliver this patient to, and also there is what is called pre-notification. Now this EMT came to this patient and he applied what is called Cincinnati pre-hospital scale. Before we have 2 scales, Cincinnati and Los Angeles pre-hospital scale, but for simplicity now we rely on Cincinnati pre-hospital. What is Cincinnati pre-hospital scale? There is 3 factors in Cincinnati pre-hospital scale. First of all is facial tone. The angle of the nose, when you tell the patient to smile, you will find the angle of the mouth deviated. then slurred speech, then extending the hands, extending the hands and palms up or down, up, to detect early CVA, it should be up. If it is down for something else, like hepatic encephalitis. Then, if there is only one factor of this Cincinnati hospital scale, it will give you a clue. What is the percentage of sensitivity percentage of getting CVA if you have only one factor of this Cincinnati hospital scale? 72%. Of 3, so it will give you 85%. Now the patient will go to the hospital. First of all, these EMTs, when they arrive to this patient and they found him, he has slurred speech or altered mentality or whatever, what is the differential diagnosis? Two differential diagnoses are very important. Exactly. So, hypoglycemia, and this is most common with diabetic patients, overdose or neglected dose or whatever. And what else? And seizures, especially post-ictal state. So in this video, we have seen that the EMT asked the patient or the family, is he diabetic? Rule out hypoglycemia. Does he got seizure before? He may be in post-ictal state. And in ambulance, if there is only one test to be done in the ambulance, what will be this test? Exactly. As we ask is to check the glucose level in the blood. Now you reach the hospital, the center where it is very equipped or well prepared to receive this support. The EMT also has to fix the time, has to get some knowledge about the onset of these symptoms. Why it is important to know the onset? Why? Why it is important? Exactly. Because this will affect our plan of treatment later on. So the EMT has to ask the family when these symptoms start. But if this patient woke up from sleep, when is onset? Yeah, last time he was seen normal. So it means that exactly. So it means that this patient has exceeded when we woke up, for example, woke up in the morning, and the last time he slept at 12 midnight, it means 7 hours or 8 hours past. It means that there is no more chance to get them thrombolytics. Okay?
The neurological assessment and performance of a CT scan should be completed within 25 minutes of the patient's arrival at the ED. This, combined with management of the patient presenting with the acute stroke, begins the 50 collection of data.
Mr. Wilson. Mrs. Wilson. I'm Dr. Wade. I'm an emergency physician here. I'm going to be evaluating you, okay? Dr. Bonner, our neurologist on our stroke team, he's on his way. Now, I know you're having some difficulty speaking, but I need to ask you some questions. So if you could just nod yes or no, that would be fine. Or your husband can answer for you. Is that all right? Okay. Now, as I understand it, she started experiencing some numbness and weakness on her right side earlier today, right? Okay. Now, what I'm going to do is I'm going to test you just a little bit, if I may. I'm going to take your hands, and I want you to squeeze my fingers as tight as you can, okay? That right hand's still a little weak. Can you lift your right leg for me? Can you do that? No, it's still a little weak too. How about your left leg? It's nice and strong. Mr. Wilson, can you tell me about what time your wife started to experience these symptoms?
It was right after brunch, about 11:25 a.m.
So about 25 minutes ago?
Yes.
Okay. Well, I'll tell you what I'm going to do. I'm going to order a CT scan for her. That way we can get a better feel for what's going on. Dana, was the CT tech alerted prior to the patient's arrival?
Yes, sir. CT was notified as soon as the EMS called the report. They're waiting on us now.
Okay, very good. Let's get it down there right away.
Yes, sir.
The CT scan should ideally be completed within 25 minutes of patient arrival in the ED and should be read within 45 minutes of ED arrival. The CT scan will aid in determining whether cerebral hemorrhage is present, which is a contraindication to fibrinolysis. If evidence of hemorrhage is present, consultation with the stroke team neurosurgeon would be the next step, and the patient would be treated for acute cerebral hemorrhage. After completion, either the radiologist or a stroke team physician interprets the CT scan. With a normal CT scan, however, as in this case, the likelihood is that the patient has suffered an acute ischemic stroke. At this stage, it's time to determine whether the patient is a candidate for fibrinolytics and decide on a specific stroke therapy. If the CT is normal and stroke is confirmed, use the fibrinolytic checklist and obtain the patient's history to see if the patient is a suitable candidate. Repeat the neurologic exam and use a formal stroke scale such as the National Institute of Health Stroke Scale or the Canadian Stroke Scale. Note if the patient's condition has improved or is rapidly improving. Finally, review the patient data to ensure that the interval from symptom onset remains under 3 hours. This represents the window of opportunity for use of intravenous fibrinolytics.
Mrs. Wilson, this is Dr. Gardner, who's our stroke expert.
Mrs. Wilson, your CT scan came back as normal, which means you have no bleeding in the brain, which is very good. Thank goodness. But we're still concerned about your condition, so I'd like to see again if you can move your arm for me at all. Has your weakness improved any? And how about your right leg? Can you try to move it again now? Okay, here's what we think is happening. The sudden onset of numbness and weakness that you're experiencing is often a symptom of a stroke caused by a blocked artery. Now, the evidence from your CT scan seems to support this because the CT scan is normal in the early hours after a stroke. Now, we may be able to prescribe some medicine for you to help you with your condition, but I need to ask you some questions about your medical history. If you can answer, that would be great, or your husband can answer for you. All right? Do you currently have a history of bleeding in the brain, stroke, or abnormal blood vessels in the brain? Any recent bleeding anywhere, or a history of clotting problems? Any recent surgeries or accidents? History of diabetes? Are you taking any prescription medication? Okay. Today, when the symptoms appeared, did your wife have any type of seizure at all?
No.
And she's never had a heart attack?
No. Never.
Okay, well, we have your blood work back. Everything looks normal. We need to make sure that your blood pressure is below 185/110. Dana, what's Mrs. Wilson's BP currently?
190 over 100.
I'll tell you what, let's give her 10 milligrams
At this point, you should know whether the patient meets the criteria for IV fibrinolytic therapy. If the patient's medical history is acceptable, if the time of onset is less than 3 hours old, and if the patient's current condition can be managed within suitable parameters, it's time to move to step 7 and discuss specific drug therapy options with the patient and family.
Hello, Mr. Wilson. Hi. Hello, Mrs. Wilson. Well, Dana tells me that we've got your blood pressure down to 170/80, and it's been, 90 minutes since the symptoms first appeared, so we're in good shape to proceed. Now, as I said earlier, we think that your stroke is being caused by a blood clot in one of the arteries leading to your brain. We've got some medication that studies have shown can improve your chances for recovery by 30%. And we can give you this medication through your IV, and it only takes about an hour. But there are some possible serious risks associated with this medication. I want to make sure that you're aware of them. There's a small possibility of a cerebral hemorrhage that's bleeding into the brain. If this were to occur, your situation could get worse. It could even be fatal. This is a small risk. It's only 5%, but I need you to be aware of it so that you can make your decision.
Well, honey, what do you think? Let's do it.
Okay, now, let's initiate fibrinolytics based on our protocol. And let's get her bed in the stroke unit. I want updates on her BPD and neuro checks every 15 minutes until she's transferred from the ED. I want to know if there's any change at all in her vital signs or her neurological status. Okay?
Okay.
After reviewing the benefits and risks of using fibrinolytics, the patient and family will need to make a decision on how to proceed. For those patients who feel the risk is unacceptable, the option exists to use aspirin to begin the stroke pathway. For those qualified patients who decide to proceed with fibrinolytics, admit the patient to a stroke unit if available, or to the appropriate monitored bed. Start the therapy within 3 hours of symptom onset, ideally within 60 minutes of ED arrival. Monitor the patient's neurologic status and blood pressure. Do not use